All right, good afternoon, everyone. Welcome to our November Teach Educational Rounds. Here with us today, we have Dr. Hassan Mir, who will be presenting on nicotine, smoking, and cardiovascular disease, risks, emerging products, and evidence-based cessation. So we'll start off as usual with our CAMH land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. And today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We'll create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. And I know some of you have already started doing this, but now is the time where you're welcome to share where you're joining us from today. I had put a link in the chat and I'll just put it in again quickly. You can use it to find out if you're not sure. And you're also welcome to add on to that and share something that you're currently doing to learn or improve your commitment to reconciliation. But yeah, keep the introductions going. We love to hear where you're coming from. And I'm just gonna keep going with my own personal land acknowledgement. My name is Rachel. I'm a second-generation Canadian located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty Number 13. And I will continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So again, we want you to continue to introduce yourselves. I'm just going to keep going with a few more items. And one of them is that, as a reminder, if you do want to receive a letter of completion for this Teach Educational Rounds, to make sure that you register for this webinar and you completed the full pre-learning assessment. Also, to make sure that you signed into this webinar using your first name and your last name, and also to complete the evaluation and post-learning assessment, and both of those will be sent out to everyone who registered at the end of this webinar. And so a bit about our presenter. Dr. Mir is a cardiologist in the divisions of cardiology and cardiac prevention and rehabilitation at the University of Ottawa Heart Institute and program chair of the Ottawa Model for Smoking Cessation. He is also an assistant professor of medicine at the University of Ottawa. Dr. Mir's clinical practice includes outpatient and inpatient general cardiology. Dr. Mir is an expert in advanced echocardiography with a special interest in interventional echocardiography. He uses echocardiography to assist with planning and guiding minimally invasive transcatheter interventions for valvular and structural heart disease. Dr. Mir plays an integral role in the division of cardiac prevention and rehabilitation, as well as in the smoking cessation program at the UOHI. So welcome, Dr. Mir, and I'll give everyone a moment to read through Dr. Mir's disclosures. And as well as some considerations around smoking, referring to commercial tobacco misuse. The information presented may not be applicable to your patient or your organization. And just, of course, one is always loving to listen and learn from you. And this is just a general note that all eligible Teach Educational Rounds presenters are offered an honorarium for their time. That being said, presentation content is not affected by acceptance of this honorarium. And the following content of Teach Educational Rounds are centered on these evidence-based guidelines that are appearing. And that being said, these materials, as well as their verbal presentation or any discussions, represent only general principles, and they do not remove the need for assessment and treatment plans by healthcare professionals. Okay, and I will pass it along now to Dr. Mir to start his presentation. Thank you so much for coming today.
All right, my pleasure. Hopefully you can see the slides.
Yes.
Perfect. All right. Well, I think we'll fly by the first few slides. Thanks so much for the invitation to present. Truly an honor to present to the rounds today. Our organization in the CAMH Group has a long-standing history of collaboration and great opportunity for us, our two great organizations, to work together to improve the delivery of care for patients who smoke. All right, so I of course have land acknowledgement from the University of Ottawa Heart Institute as well as myself in Ottawa, and just recognizing, I appreciate the land acknowledgement that's already been given, but from our perspective, acknowledging the unceded traditional territory of the Algonquin Anishinaabe and the people of the Algonquin Anishinaabe Nation. Disclosures, I think you've already had a chance to review, and including the specific mention that when we're talking about smoking, we're specifically talking about commercial tobacco use, not the traditional use as used within traditional Indigenous communities that have multiple different uses beyond just kind of that particular use. In terms of the objectives today, so we're going to review the cardiovascular harms of smoking and benefits of cessation, evaluate the evidence for smoking cessation interventions and their impact on cardiovascular outcomes, and then hopefully compare cardiovascular risks of traditional smoking with newer nicotine products such as e-cigarettes and nicotine pouches. A lot of what I'll be presenting to you is informed by this guideline that we published in the Canadian Journal of Cardiology. It's not meant to be a cardiology specific guideline. It just so happened to be in partnership with the Canadian Cardiovascular Society, and is, as you'll recognize some names on here, it's multidisciplinary across regions of Canada and beyond. This is a breakdown, and we had Prabhat Jha, who's based at Unity Health, although now he's moved from University of Toronto to Oxford to oversee their population health group. But lots of diversity across region, across specialties, across individuals. And that's just a map of that particular, of where everybody was coming from. So when we get right into this, I think I like to start off with a bit of a review of like what is nicotine. Of course, nicotine is extracted from tobacco plants, specifically the leaves of the tobacco plant. It's available through different tobacco products like cigarettes, cigar, chewing tobacco, snus, and hookah. It's a stimulant, and of course, it's highly addictive. What is the effect of nicotine? Well, nicotine takes over your brain's reward system. It kind of leverages and piggybacks on the same pathways that are activated by things like food, sex, social interactions, and their use of this product results in the release of dopamine, which then results in increased cravings of this particular product, which then increases the urge to use the product more. There are a couple of important topics, or I guess aspects to consider, like tolerance as one. Over time, your body and your brain are adjusting to the nicotine use, and so a greater amount is actually needed to have the same effect, and that's defined as tolerance. And of course, withdrawal. So when nicotine levels drop below the level that the person has developed a degree of dependence to, there's withdrawal symptoms like irritability, anxiousness, restlessness, and the craving of nicotine. It is important to highlight, and again, honestly, I had to focus my talk quite a bit, and I could probably go on for another 10, 15 slides on this, but it goes without saying that how the nicotine is delivered has a major impact and matters quite a bit. So inhalation being very different than other forms of intake. What are the cardiovascular immediate effect? I think, as we know, nicotine will cause your heart rate to go faster, about 10 to 20 beats per minute. Your blood pressure will increase. There will be constriction in blood vessels, spike in adrenaline, so people are more alert but also more stressed, and it can have an effect on sleep. So all of these in the acute setting can, of course, have adverse events from the cardiovascular standpoint as well. And we're talking about nicotine as a whole. We haven't really gone into cigarettes just yet. What about cigarettes themselves? Well, I think all of us would agree that smoking is a leading preventable cause of cardiovascular disease and death, especially among those that are smoking. Half of people that are smoking will die of a tobacco-related illness. Use of tobacco will result in a 100% increase or a twofold increase in the risk of developing cardiovascular disease, and your life expectancy for those that smoke is about 10 to 15 years shorter than those that don't smoke. And when there's intersectionality between socioeconomic groups, between mental health, etc., that number can actually be even far greater than just 10 to 15 years. It can be up to 25 years lower life expectancy. And this is not something that we just figured out 10 years ago or what have you. It's probably not in most of our lifetimes. This paper is published in the British Medical Journal back in the 1950s by Bradford Hill and Richard Dole, which associated the use of smoking and cigarette use to adverse cardiovascular and I guess adverse events in general. So this was a questionnaire on smoking and the cause of death among physicians in the UK. Over 60,000 surveys were sent out, over 40,000 completed. And this was the first study that showed a link between the tobacco use and death, especially as it relates to the use of tobacco and its association with lung cancer and coronary artery disease. And this is a quote that I'd like to share. Again, this is from 75 years ago or so. The resulting data reveals significant and steadily rising mortality from deaths due to the cancer of the lung. As the amount of tobacco smoked increases, there's also a rise in mortality from deaths attributed to coronary thrombosis as the amount smoked increases. And again, as we think about cardiovascular prevention, an area that's near and dear to my heart, I had the pleasure of working with Paul O in fellowship at the Toronto Rehab Institute. Now I'm very much involved in cardiovascular prevention rehab at the Heart Institute. Really, when we think about clinical prevention, especially among adults, for somebody that's smoking, it's the single most powerful preventative intervention in clinical practice. Short of childhood vaccinations, there's really nothing that's going to have as much of an effect on your health as smoking cessation. What are the benefits of cessation? Of course, you're going to have prolonged survival any age. Those that are able to quit by 40 have a life expectancy that's similar to those that never smoked. And in coming slides, I'll go into a little bit more detail relating to that. But even as it relates to cardiovascular disease, both in primary and secondary prevention. So for somebody who's quit for a year, their likelihood of a heart attack drops to about 50% of what it was. And by 15 years of cessation, it's the same as somebody who's never smoked at all. For those that have CVD or cardiovascular disease, smoking cessation results in a 30 to 50% reduction in future events. And if you think about post-acute coronary syndrome care, we talk about aspirin, Plavix, statin, beta blockers, ACE inhibitors. Well, the combined effect of all of those drugs from a pharmaceutical standpoint are lower than the benefits of smoking cessation. And the reality is that the majority of people do not emphasize smoking cessation to the same degree. Like, oh my God, I can't believe you missed the Plavix dose. Oh my God, like the aspirin you missed. Well, meanwhile, smoking is left largely unmanaged and unaddressed. The other aspect that's really interesting and cool is that actually management of your hypertension and your lipids for those that are smoking versus not smoking, even if adjusting for smoking status, your ability to get better control of your risk factors like hypertension and lipids is better. Your drugs are more effective for these issues than for those that continue to smoke. So just in terms of the follow-up, so that British medical doctor study, which was published in BMJ, they did a 50-year follow-up. So this is now 50 years later, published in 2004, the original one, 1954. And they looked at, well, what happened to these people over the course of their lives? So on the y-axis, you've got survival. On the x-axis, you've got age. In this blue line, this solid blue line, this is people that continue to smoke throughout the 50 years. The red line was individuals that never smoked. And then this dashed blue line was people that quit smoking at a particular age range. And that age range is listed up here. So this graph represents the 25 to 34, the 35 to 44, and then the next slide will have 45 to 54 and 55 to 64. So I'll present this slide first and then the next one later. And I actually use these slides in my clinical practice because it really helps drive home a couple of important key points. So the first is, if you're able to quit in your early 30s, your life expectancy is pretty much the same as somebody that never smoked. And even if you're able to quit by your early 40s, it's practically, for all intents and purposes, pretty much the same as somebody that never smoked. So if you're able to quit in your 30s, you're gaining about 10 years of life expectancy. If you're able to quit in your early 40s, you're gaining about 9 years of life expectancy. So I use this to showcase to my patients, the earlier you can quit, the better. The maximum, the biggest bang for your buck will be the earlier you can quit, the better it'll be for your overall health. But what about those that are increasing your exposure? Well, of course, the more you increase your exposure, the more harms of the cigarette and tobacco exposure that you're going to get. So this line shows those that are able to quit by their early 50s and this one by their early 60s. But you see that this dashed line is still kind of in the middle, even if you're in your 50s and quit, and you're gaining 6 years of life expectancy on average if you quit in your early 50s compared to those that continue to smoke. And then even into your 60s, you're gaining on average about 3 years of life expectancy. And there's a paper that was published in the last year in the American Journal of Preventive Medicine that showed that even in your early 70s, you're gaining about a year of life expectancy back. Now, I don't want to focus too much on life expectancy. You can imagine, though, that if you're gaining life expectancy, it's also the quality of life in the clinical events. I've already presented in earlier slides. But the risk of heart attacks, cancer, lung disease, et cetera, are drastically reduced. And some of the things that we do in clinical practice, like, oh my God, they got a TAVI and we extended their life by a year or two, or, we talk about cancer treatment and we're increasing life expectancy by a year or two, whereas smoking cessation is like, a tiny fraction, a fraction of a fraction in terms of the investment that would have a drastic improvement in terms of quality and quantity of life. These results were actually then, that was 2004. Now, Prabhat Jha led this analysis in New England Journal of Medicine that showed that, that confirmed that if you're able to quit by the age of 40, you're gaining about 9 out of those 10 years. And people who continued to smoke did lose about a decade of their life. And this was in a few 100,000 patients in the US. But as we think about nicotine addiction, and I saw that this was referenced, and I appreciate that. So this was the previous guideline that was published in the 2008, where they stated it's difficult to identify any other condition that presents such a mix of lethality, prevalence, and neglect, despite effective and readily available interventions. What we know is that and this is based on even several studies, but even the Cochrane reviews that have been done on this topic, about 2/3 of people want to quit, half of them will try to quit, but with just basic counseling, about 5 to 10, maybe 5% of them will be successful in quitting. Cold turkey rates about 2 to 3%. But if we're able to use the best available treatment options, you can get that quit rate up to 50%, like 30 to 50%, depending on the population. And the reality is that people who are smoking are pretty informed. At least in Canada, they're quite informed. So a big group lecture isn't necessarily the biggest bang for our buck. They need help. They need operational help to actually help them get over that, serious addiction that they're undergoing. And from our perspective, that means being very clear, very strong and personalized with unambiguous facts about the harms of smoking, the benefits of cessation, but of course doing so in an empathetic and non-judgmental manner. And this is where organizational commitment for all of us, and this is where we need to push our organizations to do more, to push them towards best practices, is extremely vital. So I'm not going to go too much into details. I think later on in the slide deck, I'll talk a little bit, about the OMSE program in case people haven't heard of it. But the long and short is that there are system-based interventions, and then there are individual level interventions. We'll go through the individual level interventions and then get into some of the other aspects later. So when we think about approach to smoking cessation, I think this is for everybody here, but really the behavioral counseling is a cornerstone and should be offered to all patients. We typically will think about the 5 A's, although that's now transitioning more so to the 3 A's, which is the ask, advise, and act. But the previous one's looking at the assessment and assistance, as well as arranging and follow-up for individuals. And this is based on motivational interviewing aspects with the 5 R's, with making sure that what we're doing is relevant to the people that are actually, in front of us. So a 20-year-old is going to be treated very differently than a 60-year-old. And of course, the risks for the 20-year-old are going to be very different than the 60-year-old, as you probably already saw with those graphs that I often share with individuals. The benefits of rewards, of course, if you were to invest that money into the markets compared to for somebody who's young, that can be a major financial improvement and reward. But even for those that are, thinking about, hey, I don't want to be a bad influence on my kids or their grandkids or what have you. Just thinking about all of those aspects, recognizing there will be roadblocks. There's no magic bullet here that's going to figure everything out. And most people try to quit about 7 to 10 times before they're successful. So really recognizing the need for repetition. And of course, the need for follow-up. There's been Cochrane reviews that have been done with, behavioral counseling interventions. But if there's less than 1 month of follow-up, there's no significant improvement in quit rates. The odds ratios and the confidence intervals cross 1. So you need at least 1 month of follow-up, if not more, to ensure that there's sustained quit rates. And as we move into the pharmacotherapy aspect, well, pretty much anybody that's smoking should be initiated on pharmacotherapy, except in very specific and special circumstances. And the reality is that it'll drastically increase their likelihood of success to quit if using pharmacotherapy. So what are our pharmacotherapies? So we break it down into NRT or nicotine replacement therapies or non-nicotine replacement therapies. And you'll see bupropion, varenicline, and cytosine listed here. This is again from that treating tobacco use dependence clinical practice guideline. And what they had done was assuming a placebo rate, quit rate of around like 10 to 15%. What are the relative effectiveness of these other products? Well, varenicline is getting you to about 30 to 35%, and combination NRT about 35% or so. Bupropion is about 25%. And since that time, there's been a Cochrane network meta-analysis that's been done that looks at both direct and indirect evidence of over 300 randomized controlled trials with over 150,000 participants that were randomized. And compared to control, of course, over time, the control or placebo groups are only getting stronger. But what you see is there continues to be a doubling in quit rates compared to compared to control or placebo with combination NRT, and same with varenicline and cytosine. They practically are doubling quit rates, whereas bupropion's about a 40% increase, but still a significant increase. I've put in nicotine e-cigarettes here as well. I think that's a controversial topic. It's not something that we consider a first-line treatment in Ottawa at the Heart Institute and the Ottawa Model for Smoking Cessation. I just put this here for completeness sake, so everybody, is transparently seeing that based on the short-term studies that have been done, there is some evidence in the short term that e-cigarettes are helpful for people to quit. So in terms of the different products, just going into a little bit of detail, so nicotine replacement therapy, of course, I think the rationale is pretty straightforward. You've got an addiction to nicotine. We're going to replace that with safer alternatives and forms of nicotine. And the usual products that we'll use are something like a long-acting patch, and then combine that with gum, lozenge, inhalers, or sprays, and things like that. And the idea really, I often, when I'm talking to trainees or people that are kind of working in this particular area, the idea is kind of thinking like how we would manage insulin, right? Like you've got the long-acting patch, which would be kind of like the long-acting insulin. And then you've got short-acting, just like you have short-acting insulin when somebody has spikes in their blood glucose because let's say they're eating or something. Well, with nicotine dependence, the reality is a spike could be various issues, like maybe something stressful is happening, or maybe, they have a coffee or alcohol, and that's their associated use of nicotine and what have you. So just, we use combination that's significantly more effective than using one or the other. And the advantages really are truly to empower individuals to take control of this addiction that they have unfortunately developed, which is to say that they can actually use as much or as little short acting as they want. If they feel like they're getting more withdrawal symptoms, they can use more, and if they're having less, they can use less. So it's not like somebody's like, hey, you need to do X, Y, and Z. It's actually like, hey, you can use as much or as little as you want, so empowering them. But it's not without its own issues, of course. Like there are side effects of these products. The patch often will cause a little bit of irritation on the skin. Some of the oral products can cause some gastrointestinal upset, like heartburn and things like that. There's associated weight gain with NRT, which is not seen in other cases. But so there are some shortcomings. It's not perfect, but there are definitely ways to address some of those side effects that occur, to address them and try to overcome them and help continue to use the products. When we think about the dosing or the idea of nicotine, I know this is going to be a review certainly for those that are in attendance, but I thought it would be helpful as a concept overview. So on the y-axis, you've got plasma nicotine concentration. On the x-axis, you've got time. Focusing on the top part of the slides here, you've got this red line. That's kind of the dependence that the person has developed. And if their blood concentration goes below this, they start getting withdrawal symptoms. If above it, they feel quote unquote normal. So the black line represents when they're smoking, they're trying to get their blood concentration above this red line. But as soon as it drops below, they start smoking, and that is meant to try and address their withdrawal symptoms. What we're trying to do is try to use safer products. So like you've got this orange line, which is your nicotine patch, and then you've got this turquoise line, which is gum. And the idea is that you have, when you add up the peaks of these two lines, hopefully you will remain above this red line to address their withdrawal symptoms, to hopefully then come off of cigarettes entirely and titrate these as needed. And then also after several weeks, once they have been stable off cigarettes and confident to stay off cigarettes, then we'll try to wean off of the patch while topping up with short acting as needed, until such point that the patch is no longer needed and they may just use the short acting as needed. And I have a colleague of mine who's a cardiologist himself who used to smoke, quit back in 2012-13. Even to this day carries around short-acting nicotine replacement therapy. And the reason is because, if he's doing something busy in the CCU and what have you, he still gets withdrawal symptoms. And he said, unfortunately, the reality is that once you've had a dependence or addiction to nicotine, it's not something that just disappears. You're one cigarette away from a relapse. So for him, at least, he's found it helpful and comforting to have some degree of short-acting NRT available when needed. And certainly the harm reduction aspect of that is much greater than the potential for relapse, than the risks associated with relapse. And to that end, obviously, as clinicians, we are going to titrate the dose and the duration of treatment as we need, and of course, use the combination. Like there might be guides that exist within monographs and what have you, but the reality is that we have to personalize care for the people that are in front of us to use these medications, as appropriate. Moving on to the non-NRT products, so I think, again, a bit of a review. Bupropion inhibits the reuptake of dopamine and norepinephrine, may relieve or suppress nicotine withdrawal symptoms, and acts as a non-competitive antagonist to nicotinic receptors. The benefit being no cessation weight gain, which NRT is associated with. There are some other side effects like insomnia, agitation, dry mouth, and headache, and these are common even for those that are using nicotine. The receptor that's being used is a cholinergic receptor, and so these are symptoms that can occur when that receptor is activated. The one thing to be mindful of is there is a slight increase in epileptic seizure when using bupropion, 0.03% compared to general population. And in light of that, if there's somebody who's an active epilepsy or is unstable from their epilepsy standpoint, or if they have anything that reduces their seizure threshold, like a head injury or alcohol abuse or an eating disorder, then these are the types of things that you would have to be quite careful in the use of this particular drug. Moving on to varenicline. So varenicline is really interesting because it binds the same receptor that nicotine binds, the alpha-4 beta-2 receptor. And in doing so, it stimulates the release of dopamine and all the usual stuff that nicotine does. So in that way, it's an antagonist and an agonist. So it agonizes or is an agonist to that receptor that nicotine works on, but also does not allow the binding of nicotine, and in that function is an antagonist to nicotine. And so what happens is that even if somebody's smoking, well, if all the receptors are taken up by varenicline, the additional amount of nicotine doesn't have anywhere to bind the receptors to lead to more dopamine release, et cetera, et cetera. So often people will say, I don't get that same joy that I used to get from smoking anymore. And the reason is because the receptors are obviously opened, and again, benefit no weight gain. The most common side effect that we're often told about is vivid dreams. But again, with dose reduction, I've had excellent success, instead of 1 BID going down to 0.5 BID or 0.5 daily. And that seems to have had good effect. Again, we think about treating a 100-pound person as the same as 150, 100-kilogram person, and the reality is that two people aren't the same. So being nimble with our dose titration is going to be important. And with varenicline, really, the primary contraindication would be somebody who has an allergy to it. What about from a cardiovascular standpoint or psychiatric issues? Well, the EAGLE study was done back and published in Lancet, a landmark study that was done comparing varenicline, bupropion, combination NRT to placebo, over 8,000 people. And they looked both at neuropsychiatric events as well as cardiovascular events. And the long and short is that they did not see an increased risk of either compared to placebo. So what they did was those that had baseline psychiatric conditions or those that did not, they had 1,000 approximate people in each arm, and you see that any adverse events and severe adverse events are very similar to that, or there's no difference statistically compared to placebo for those that did not have a baseline psychiatric issue or those that did. Of course, those that have a baseline psychiatric illness that's been diagnosed will have an overall higher level of incidence in general, but no difference between groups. So that resulted, and along with this, the sub-study published a few years later for the cardiovascular events. And the long and short of that, these resulted in the removal of warnings that were previously listed for these drugs, but no longer exist. And this is the landmark study that resulted in that. And of course, there's been several systematic reviews and meta-analyses since this time that have confirmed the safety of these drugs. What about cytosine? Some of you may have already heard of this product. Some of you may have actually used this in your practice. If not, then this might be a nice overview of this particular product. And so what do we know? Well, this is published in CMAJ in 2018, so almost 8 years ago now. It mimics the effects of nicotine by virtue of it working on the same receptor that varenicline does. So it's kind of a natural formulation of varenicline, or a natural version of varenicline. Mimics the effect of nicotine, and of course, varenicline, not a new drug, effective for smoking cessation. It's actually available in Canada without a prescription. You can go to a natural health store and get the product if you would like, and it's cost effective. One of the biggest barriers, though, for those that work in this game of smoking cessation, it has been the dosing regimen, which is that, it's a capsule every 2 hours for the first few days, and a capsule every 2.5 hours for the next week, then a capsule every 3 hours for the next few days. And the reality is, like, even me saying this, I'm getting exhausted. So imagine having to write this all out. It's challenging. We did a randomized control trial that was published earlier this year for the use of cytosine versus combination NRT for relapse, for those that had relapsed, and found that less than half of people randomized cytosine were able to actually comply with this regimen. And it's only like a 4-week regimen, but even still, it was very challenging to get people to stay on to the drug. What about cost? Well, NRT, if you're just thinking about a patch or like gum, it's about $500. Bupropion is probably $200 to $300. Varenicline maybe about $300 to $400. Cytosine nowadays for a bottle with this particular course is about $75. And as you saw earlier, the odds ratio of success for cessation for cytosine's old school dose is pretty well similar to that of NRT and Varenicline and significantly higher than bupropion. And you see that it's a fraction of the cost. So I think there's a lot of push to do more work in this particular area. And I'll present some of our upcoming research trials in upcoming slides, just to kind of give a bit of an overview, recognizing, of course, that we've got an opportunity to share some of the work that we're doing. There's even been a Cochrane review about cytosine and varenicline, and what they did was they combined the effect of varenicline and cytosine compared to placebo or NRT, and they find that cytosine is more effective than placebo and NRT, similar to varenicline, and it does have more side effects than placebo or NRT, but less compared to varenicline. So that rounds out some of those things. Those are kind of the usual suspects. They're considered quote unquote first line treatment options. Well, what about other options? Because I know that there was an interest to kind of hear a little bit about these emerging nicotine products as well. So I think this is a complicated topic, and literally you could spend the whole day talking about e-cigarettes. I could spend the entire, literally spend the entire day on this particular topic of e-cigarettes and what have you. But there are pros and cons to using e-cigarettes. Of course, the potential harm reduction tool, they're less harmful than cigarettes in the short term. And I guess, all of us, there's consensus that e-cigarettes are less harmful than cigarettes. 7,000 plus chemicals versus 10, 20. Clearly, e-cigarettes are considered based on consensus to be less harmful. There's Cochrane reviews that have been done that show high certainty, strong evidence that e-cigarettes are effective for smoking cessation at 6 months. As I mentioned earlier, the twofold increased odds of smoking cessation compared to placebo. And there is there's no short-term harms, but that is obviously limited by the fact that we don't have long-term data. The cons, obviously, they can deliver the same, if not greater, nicotine than even cigarettes. In our randomized controlled trial for vaping cessation, 10% of people, like 10 people or something, were using 100 milligrams of nicotine a day. The amount of nicotine we needed to replace was immense, and only for them to manage their withdrawal symptoms. There is some pathomimetic effects, which of course can increase the risk of ischemia and cardiovascular disease. There's limited safety data, and there's harm signals based on some of the initial studies that have been done. Rising recreational use is a big problem, especially because there is an association to tobacco use or conventional cigarette use among those that are using e-cigarettes, e-cigarette products. And the most important one, which I often ask clinicians whenever they ask me, about my stance on e-cigarettes, like there's no approved product, there's no approved dose, there's no frequency. So really we're kind of putting our patients out to the pasture to say, oh, do whatever you think is appropriate for you, right? But there are obviously challenges, and most of these e-cigarettes are owned by the tobacco industry, if not all. Again, this is a network meta-analysis that I kind of presented earlier, which does show that there is that 2.4-fold increase based on 16 trials, but only less than 4,000 participants. Like cytosine has more participants in 7 trials than even nicotine e-cigarettes, and most of the people haven't really even heard about cytosine. When you compare e-cigarettes to something like, varenicline, there's 16,000 patients worth of study. You look at nicotine patch is close to 40,000. So we're really far away in terms of making definitive statements about these products, and definitely lacking the long-term data. That's one of the biggest concerns. And this is just kind of another mechanism of demonstrating that. This is a nice figure from that network meta-analysis that allows you to compare different products head-to-head one another based on both direct and indirect evidence. So you can see nicotine e-cigarettes compared to cytosine, for example. Well, in the direct or indirect evidence, that they don't have a significant difference between the two. But when you look at, let's say, cytosine to placebo, it's substantially higher. So anything that's bolded in this particular figure implies that that's a statistically significant finding. If it's not bold, it's not. So I'm not meant to go through all of this. It's meant just to be a demonstration, and you can go back to this Cochrane Review network meta-analysis. And if any ever wondering about head-to-head comparisons, this is a great figure that I often turn to. But again, the reality is that the serious adverse events they're rare, but I mean, they're only tested for 2 years. And I would ask anybody that's a massive proponent of e-cigarettes to say, well, if somebody were to smoke for a year, are you sure you're going to be able to demonstrate based on 4,000 patients that there's a significant increase in myocardial infarction or mortality or whatever? No, it's 1 year worth of data. And even if we talk about the quote unquote the most dangerous thing that I've the most harmful thing somebody can be doing in the majority of cases, and you're not going to get data that shows statistically significant difference even at 1 year follow-up, right? So I think we need to be quite careful, recognizing that there is a major lack of long-term outcomes. And of course, we have drugs that have been tested in larger populations for decades that are equally as effective, at least, and obviously safe. So I'm very much, this is like a 5th or 6th line product that one could consider. This is something that was published in the New England Journal of Medicine, where they looked at the odds. Again, there's some challenges to this paper. It's low quality evidence. It's based on observational studies. The biggest takeaway that was published and led to a lot of controversy was that they suggested that e-cigarettes and cigarettes, based on the odds ratio for cardiovascular disease, stroke, metabolic dysfunction, asthma, COPD, and oral disease, the odds of you having something with e-cigarettes only versus cigarette only crossed 1, meaning that there's no significant difference. So what they're implying with this is that the harms to these outcomes for e-cigarette users were the same as those that smoke cigarettes. And that is a shocking finding, to be honest and frank, because the consensus has always been actually e-cigarettes are not as harmful as cigarettes from a biochemical standpoint, et cetera, et cetera. And the criticism here, though, is that e-cigarettes, they did not control for those that were former smokers. And of course, we know that exposure to cigarettes and former tobacco use is going to have a direct effect on your long-term risk of every single one of these things that is mentioned here. But what I actually take away is not their primary conclusion. What I actually take away is the second line, which I've bolded in red. So if you did not expect that there was going to be a significant increase of harms of e-cigarette use on top of cigarettes, because again, we say cigarettes are among the most harmful thing, if not the most harmful thing for most people, then the use of additional e-cigarettes should not have much of a difference compared to cigarettes, because cigarettes are the harmful aspect of it. So when you're comparing these two arms, hopefully there should be similar outcomes. But what you actually see is there's an increase in every one of these outcomes, and short of the cardiovascular disease, pretty much one more study will push this over the edge. But every single one of them, except for that, is significantly increased risk of dual use compared to cigarette use only. And even cardiovascular risk is trending towards higher. So this is not the only study. There's lots of other studies that have been done that have highlighted that there may be increased risk, of course, of these products, but more studies are needed. Our group actually published a paper looking at, I think, 1,500 Ottawa Heart Institute patients and looking at e-cigarette users. And we found that those that were e-cigarette users had significantly longer length of stay in hospital compared to those that were not e-cigarette users, even when adjusting for tobacco use, either current or former. What we found was those that were former e-cigarette users had about a 1 or 2 day increase in length of stay, and current e-cigarette users about 3.5 day increase in length of stay. So, I think we're starting to see some, soft evidence. I'm not going to say that this is strong evidence, but it is cross-sectional evidence that's coming, and we'll have to see. And of course, this is a figure that was colleagues of ours from CQTS in Quebec had developed. We're updating this, and hopefully in 2026, there will be more updates that are coming relating to this. But again, I think from a biological, physiological standpoint, we know that there are, of course, associated harms of nicotine, and of course, with the amounts that are being used, it's definitely something that we're concerned about. If you're thinking about vaping cessation, well, the first systematic meta-analysis our group had, the honor of publishing in the British Medical Journal of Tobacco Control. We have an update that's currently underway. The long and short is, at the time, there were 7 randomized controlled trials. The numbers have increased in our update at this time. And the long and short is that 7-day point prevalence with these interventions that included digital pharmacotherapy and education significantly increased rates of vaping cessation, and even on, again, we have more detail in the actual paper, but even on subgroup analysis, regardless of the duration of follow-up, regardless of the type of intervention, there was a significant increase. Also continuous abstinence rates, but again, whereas the 7-day point prevalence was more commonly tested, and so moderate certainty, the other outcomes are lower certainty evidence. So as we think about smoking cessation, I hope that we all consider, certainly from the cardiovascular perspective, but even in general, the single most powerful preventive intervention in clinical practice. And it's our responsibility, really a fundamental responsibility for anybody who's looking after patients to assess and assist individuals who smoke to help them reduce or quit. But that does require transforming our institutional practices, professional behaviors to then hopefully improve patient care. And just a little bit of background about our program for those that may or may not have heard, we have the Ottawa Model for Smoking Cessation, a simple step-by-step coordinated approach for addressing tobacco use in healthcare settings, which focuses really on 5 key pillars every single patient in clinical practice should be identified into their smoking and vaping status, documenting that so everybody from the team can see it, providing strategic advice, even if brief, initiation of pharmacotherapy for every single person, and ensuring that there's sufficient long-term follow-up for them. And our program offers up to 6 months of free outpatient follow-up, along with the nicotine replacement therapy through the CAMH Stop program as well, of course, for 26 weeks, but also for 6 months of telephone follow-up, 10 to 12 telephone visits for follow-up. We've reached over 500,000 people, approximately 600 sites, or actually more than 600 sites have implemented across Canada, and 8 different countries have also implemented, and we've trained over close to 50,000 healthcare professionals in sessions like this. In terms of program outcomes, I'm not going to waste too much of your time, but process level improvements in over 4,000, or close to 4,000 patients when OMSE implemented. Smoking cessation rates 70% increase from 18 to 29%, and even when partnering with colleagues in Toronto about with ICES database, showing that there's a significant improvement in healthcare utilization, so reduction in all-cause readmissions, smoking-related readmissions, and ER visits, and even at 2 years, those results remain, and also there's a significant improvement in mortality, recognizing the benefits of cessation, the smoking cessation program is able to accomplish. And that's been assessed, because I didn't actually believe this when I first saw this, but colleagues in London, UK, as well as Taiwan have confirmed implementation results in a mortality benefit. Specifically, obviously, this is a smoking cessation program and to help people quit. From a cost-effectiveness standpoint, we save about 20% in cost to the healthcare system, and we do have evergreen funding from the Ministry of Health. There is a study done by Ontario Health, long and short is that implementation in lung cancer screening programs and comparing different programs, almost 7,000 participants, showing that OMSE had almost double the quit rates at 1 year compared to the other programs that were also evaluated. So really our focus is to try to maximize our impact, which means working on effectiveness as well as reach. These are some of the projects that we currently have underway in implementation research. So the Connect study looked at 5 different provinces and territories. We have an evaluation in PEI, both about the provincial-wide implementation of OMSE as well as the effects of COVID, which has been quite positive from the resilience of the program. We have the BREATHE study actively implemented in Indigenous communities, long-term outcomes, looking at 3-year outcomes for OMSE program, not just 6-month outcomes. And we have an active implementation, hopefully partnership with Ethiopia, and a new one building in Nigeria. And these are just some of the randomized controlled trials that our group is involved in leading. The Cessation versus NRT for relapse that's published. The Step 1 is a smartphone app to help motivate individuals that are smoking and not interested in quitting to try and quit smoking. And then we've got a study called ASAP, varenicline plus e-cigarette versus varenicline, to see long-term benefits or harms of e-cigarette use. In that particular population, CanQuit is comparing NRT, simplified dose of cytosine, with the 3 milligrams 3 times a day that's been tested in smoking and vaping cessation and felt to be effective. So we're testing that head-to-head. Initiate looking at smoking cessation in emergency departments as an 800-patient CIHR-funded randomized control trial. We have the largest randomized controlled trial in vaping cessation using NRT. The last one is about 20 patients. We're recruiting 200 patients, or 180 patients. We're at about 170, hoping to report results in 2026 relating to that, and hopefully will inform the initiation and titration of NRT for these individuals. We have a semaglutide plus NRT versus semaglutide for smoking cessation, which is informed by a systematic review that's currently in revision and hopefully will be published in the coming months. And then the last one, which is looking at vaping cessation using varenicline, cytosine, or placebo. So if there's any interest for anybody who's in attendance to chat about any of the work that we're doing, any of the trials, any implementation, we'd be more than happy to chat. In terms of the summary of the session, just so we have 10 minutes for Q&A, this is kind of the dosing schedule, 1 to 2 milligrams of the patch with short acting on top. This is the bupropion varenicline. This is just some figures that we had within our guideline published in the Canadian Journal of Cardiology that just emphasizes the things that really should be focused on, along with a 1-minute consult at smoking cessation that anybody can and should hopefully be able to do within a minute, with quotations of what people could actually even say as a script if need be. So welcome any feedback and welcome any collaboration opportunities. I'll just put another last plug. I apologize for all the plugs, but think this is a great opportunity for us to build more connections and collaboration between our teams. But we do have our conference, the largest conference in Canada on smoking and vaping, largest annual conference on smoking and vaping cessation. There is no abstract competition. We usually have fantastic, representation from the group in CAMH, and so would love to see you all there and love to collaborate going forward. Thank you.
Thank you, Dr. Mir, for such an engaging webinar. And I appreciate you leaving some time for questions, because we do have quite a few in the chat that I'll get to just in a second. So let me go through the questions actually right now. Catherine was wondering what your thoughts are on nicotine pouches, which are getting a lot of airplay on TV.
That's an excellent question. And what I might do, because I literally just before this gave a talk to the family health team at UHN, is our group has published a couple of papers on this topic within the last month, I would say. What we have found is that there's actually no evidence that suggests, based on systematic reviews and meta-analyses, that nicotine pouches help people quit smoking or that they reduce smoking by any more than what a nicotine gum can do. So I will just take 10 seconds to share my slide again, and I'm happy to add that in the next in the slide deck, because I don't know if you can see this, but
I can see
perfect. Okay, fantastic. So this was, I'm not going to go into the presenter mode, but just this was a publication that we published in the Drug and Alcohol Dependence Reports. This is published about 3 weeks ago on pharmacokinetics of smoking, of nicotine pouches. Nicotine uptake from pouches can meet or exceed that of cigarettes. So if you're at 6 milligrams or higher, you actually get more total nicotine and more peak of nicotine than even a cigarette can deliver. And higher doses, but also flavored nicotine pouches have a 25% higher nicotine exposure than unflavored. Now you can imagine what the tobacco industry tested when they were doing their pharmacokinetic studies, unflavored, and what they're marketing to everybody and what's being used, which is flavored. So I think that's a key finding of this particular paper, and I put the QR code here, and again, happy to add that slide at the end. The other one was this, and this is the first systematic review meta-analysis on this topic ever published on nicotine pouches pharmacokinetics. This is the first systematic review ever published of the clinical outcomes of nicotine pouches. And what we found, long and short, is that there's no increase in the rates of smoking cessation compared to NRT or control. Shockingly, like there's no increased rates of smoking cessation compared to control for the use of nicotine pouches. And this is largely due to a lack of evidence and long-term evidence. So more stuff needs to be done. And there is a reduction in cigarette use, but no more than would be achieved through nicotine gum. So our conclusion based on that publication, based on those findings in the review, is that until more large-scale independent trials are completed, nicotine pouches should not be considered an evidence-based cessation aid, and caution is warranted on their use. So hopefully that makes our stance clear.
Thank you for sharing that. We had another question with regards to people quitting with e-cigarettes. What is their status of continuing to use e-cigarettes after quitting tobacco cigarettes?
Sorry, so what is the, when people are using e-cigarettes to quit, what is the status of continuing e-cigarettes after quitting? Excellent question. I think this is not, so when we did our systematic review on the use of e-cigarettes or smoking cessation, this was one of the things that we wanted to look into, but it's not actually regularly reported in terms of what was the continued use of e-cigarettes. Like that's a major outcome. And if we talk about 5% by 2035, as federal government has suggested, like, I think we need to broaden our horizon to nicotine use or recreational nicotine use by 2035, because you're switching from one addiction to another, which again, you can often get way more nicotine exposure than not. The other thing I'll just caution people about, so there's been studies, so when people are using e-cigarettes, it's like, I'm smoking, I want to quit, I want to use e-cigarettes as my way of quitting, and I plan on quitting entirely. Okay. When they've done studies where e-cigarettes have just been given to people who happen to smoke, but were not really interested in quitting, there was a 50% increase in the number of cigarettes smoked. So they went from a mean of 20% to a mean of 20 cigarettes per day to a mean of 30 cigarettes per day, published in the BMJ, thousands of patients, right? So all to say that you can actually potentially increase your potential nicotine total amount of nicotine. What I really worry about, honestly, is that there's short-term success with e-cigarettes, but the 70% or so people that do not achieve successful quit may actually end up smoking more. So the total number of cigarettes that are smoked may not actually be all that different compared to the total population. Like, yes, we got 30% people to quit, which is wonderful. I think as I said, I'd be a hypocrite if I said otherwise. I think smoking is the most harmful thing most people can do for their health. However, I do feel that there is this concern, and we need more evidence on this before it becomes anywhere near first line. As I said, it's like a fifth or sixth line once people have failed multiple different options, and they're thinking about doing hypnosis or laser. Okay, let's have a discussion about this. So I mean, it is a form of NRT, but I think we need to think about what we need to be mindful of its use. And like I said, if you have 2 years worth of quote unquote safety data, would people feel comfortable with 2 years worth of smoking data from 100 years ago and say, yeah, actually, tobacco is not harmful? Well, that's what the tobacco industry did 100 years ago. That's how they convinced people that cigarettes were not harmful, with short-term outcomes. And I think we need to be careful. Most of these companies, most of these products are owned by the tobacco industry. So I'm very hesitant to use them in clinical practice.
Thank you. There was another one asking if cytosine has the same potential side effects as Chantix.
Yeah, it's a great question. So cytosine has lower side effects based on the trials that have been done compared to varenicline, right? So that's been shown in the studies that have been done. Our trial of 1,650 patients, the Can't Quit trial, is 1,650 patients being randomized to varenicline, cytosine with a simplified dose that we want to evaluate, and combination NRT. Will give great head-to-head information about the relative efficacy, but also the relative safety of these drugs head-to-head, and the discontinuation rates, et cetera, et cetera. So what I would say is that, yes, it would have similar side effects. It does have similar side effects, the vivid dreams and all that stuff. And what I've typically done in my clinical practice, because I've switched more towards the simplified dosing, so if people are having side effects, instead of 2 capsules 3 times a day, I just go down to 1 capsule 3 times a day. And if they're still having side effects, then we'll do 1 capsule in the morning and afternoon and skip the one in the evening. And if they're still having side effects, we'll do 1 capsule in the morning. And honestly, I don't think I've had anybody actually drop out or like stop using it entirely yet. And I've probably used it in about like 30, 40 people. So it's still early days. I don't want to come up here and say, oh, cytosine is the best thing in the world. I will say, having presented grand rounds and several different rounds, we have collaborations in Nunavut and Northwest Territories. And several Indigenous people have come up to us and said, we feel cytosine would be, and Indigenous providers who provide for Indigenous patients, that cytosine, because it's natural and plant-based, may actually be a possible attractive option for some of the Indigenous patients who do not want to take pharmaceutical drugs, have a major distrust of these products, and would much rather use something that's natural and plant-based. So I think there may be a potential opportunity for the use of cytosine in those populations.
Great. And then Stacy wanted to know, does the nicotine delivery mechanism cause different levels or types of lipid effects?
Does the nicotine delivery mechanism cause different types and levels of lipid effects? I'm not aware of that, whether there is a difference in terms of the mechanism and lipid effects. Like, we know that smoking is directly, there's many different aspects of smoking tobacco, conventional tobacco, with combustion and the chemicals in it that causes your levels of inflammation and biomarkers to be affected. Whereas with nicotine in and of itself as a substance, without that combustion, I'm not personally aware of the adverse events from a lipid standpoint. What we do know is for people that are continuing to smoke, statins are less effective than those that are not, right? So, and antihypertensives are more effective among people who quit or are not smoking compared to those that smoke. So the effectiveness of the drugs that we use is altered by smoking. I'm not, honestly, I accept my deficiency. I'm not aware of how a nicotine pouch or a nicotine gum or any nicotine product would affect lipid effects. My understanding is more so from a combustion standpoint.
Okay, thank you. And then we had one more question from Lynn, who was hoping you could compare nicotine spray to the pouches for effectiveness in smoking cessation.
Yeah, so it's a great question. We don't have any head-to-head data of nicotine pouches to pretty much anything other than a single study of gum, right? So I don't think nicotine pouches should be used for smoking cessation. I'm pretty clear about that. I think we have better products that are better studied, that have safety and efficacy data in the tens of thousands of patients. And just because this is hot right now does not mean that, in my opinion, that they should be used clinically. I think, and we're very clear about that in our papers that have been published, and what we recommend to our sites is that these products are not evidence-based. They might be used consumer-wise, and tomorrow they're in the US. They're talking about having nicotine drinks. They're talking about nicotine toothpicks. Like, what's next? Like, is everything a harm reduction tool? Like, where is the bar before we say something is or is not evidence-based, right? Like, we need evidence before we suggest this. So what I would say is that nicotine pouches, there's no comparison. There's never been a study, and also nicotine products like the short-acting products are proven and evidence-based, and they should be preferentially used. Now, if somebody says, I've tried it all, I've been through vernicillin, bupropion, cytosine, NRT, the 10 different formulations of NRT, I've gone to, blah, 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 whatever, and I really want to try a pouch, I've even tried e-cigarettes, I really want to try a pouch, and that's the only way I'm going to try to quit. Sure, we can talk about that. I'm not, an all or nothing type of a person, and nor is our program. I think we need to be personalized, but I think we need to be very careful that these are not evidence-based products. They do not have evidence to back their use, and we need to be careful in recommending them to our patients.
Thank you, Dr. Mayer. Thank you for taking the time to answer all these questions. We are at 1, but if any questions come up, you're welcome to connect and reach out. I'm just gonna finish up with, again, some final reminders, but I know we're at 1, so if anyone needs to leave at this point, that's completely okay. And so just a reminder that if you would like to receive your letter of completion for this Teach Educational Rounds to complete the evaluation and post-learning assessment, both of which will be sent out to you. And we'll have another Teach Educational Rounds next month, our final one of the year, on women and diabetes with Dr. Osnat Mohammed and Alexandra Giordano, which are both from our lab, so we're excited for that. And you are welcome to look at our website to check out one of our archive webinars or complete one of our self-study activities, or rewatch a webinar again if you missed one of them. Thank you, though, for now. Thank you, everyone, for coming. Dr. Mayer, I'm not sure if you can see in the chat, but you're getting a lot of thank yous, and people enjoyed the presentation just as much as I did. So thank you for coming today. And I hope everyone enjoys the rest of the day.